Okay, I started the recording. So we're going to be watching some videos on transfer, transport, and then we're going to do a group activity on positioning. So the activity will be, I'm going to break you up into 3 groups, and then you're going to put together a little mini presentation in your group using Google Slides, or you can use PowerPoint if you want, it doesn't really matter, but I was thinking you guys could work simultaneously if you did it through a Google slide. For the 3 different types of positions we're going to be looking at in lab this week. So we'll be looking at supine, prone, and lateral. So we'll do a little group activity with that. Okay, so that's the plan. That's the objective. Nothing due today. For the LVL upload, for the live virtual lab upload, you will post your link for your group project, okay, that you're gonna do. So each individually post that, if you will. That will be your activity for Blackboard. And that will need to be uploaded if you want attendance credit, okay? Questions, comments, violent reactions? Okay. All right, so maybe there'll be some violent reactions after we watch our first video. So we're going to get on with that. I tried to put them all in a row, so let's see how I did. I tried to line them up here. 1 second. All right, this first chair, yes, this first video is about wheelchairs. I think I need more coffees. Okay, here we go. I gotta make it big, hold on. Okay. I like the elevator music.
Wheelchair safety is an important part of your role as a volunteer with Brant Community Healthcare System, as you provide support to visitors, patients, and their families, and help to enrich the hospital experience. In the next few minutes, we will consider various aspects of wheelchair safety as you may encounter it in your daily volunteering routine. We will consider the parts of a wheelchair, how to safely open and close a wheelchair, tips for transporting a patient, setting up a patient to transfer between surfaces, and other special considerations. There are various types of wheelchairs you may encounter within the hospital, including manual wheelchairs, nesting chairs, often called the shopping cart chair, and transport chairs.
The airport chair.
Although there are many intricacies to a wheelchair, the key aspects you will encounter transporting patients are armrests, footrests, which can be swung outside of the transport and manual wheelchairs, push handles, and brake levers, which differ depending on the wheelchair used. On a manual or transport wheelchair, brake levers are located on the left and right of the wheels. On the shopping cart wheelchair, brakes are automatically engaged. To release the brake, push the bar on the chair forward, then proceed with the transport. To ensure patient safety and avoid a sudden stop, come to a stop first, then release the brake bar to engage the brake again. You may have the opportunity to set up a wheelchair for a patient, or return a wheelchair following assisting a patient, when tips on opening and closing the wheelchair will be of value. To open the wheelchair, stand facing the chair. To ensure your fingers don't get caught, place palms on the outside of the seat with your fingers facing inward. Push down and outward until the chair is fully opened. Place the cushion, if applicable, on the seat. To close the wheelchair, remove the cushion and set aside. Lift the footrests up. From beside the chair, grasp the front and back of the seat and pull upward. Part of your role as a volunteer may include transporting clients between rooms, to hospital appointments, or to their awaiting vehicle. For the safety of the patients and volunteers, volunteers have not been trained and therefore should not lift or transfer patients. When preparing to transport a patient between destinations, introduce yourself and explain to the patient what you are going to do.
Hi, my name is Marina. I'm going to take you down the imaging now. Okay, so I just need you to put your feet up like here. And just lift up a little farther. That's it. And this one too. Put your arms on here and just keep them in there. That's right. Now just going to disconnect you from here. Comfortable? Yes, fine. Okay. Now, there's a break here, so I'll just release that. And I'll release this one also. Okay. I'll take you for down the imaging now.
For transport, assist the patient in placing their feet on the footrests, reminding the patient not to stand on the footrests. Assist the patient in placing their elbows on the armrests. And ensure all tubing, IVs, and clothing are positioned where they will not be pulled out. As you transport the patient in the wheelchair to the selected location, use both hands to push the wheelchair handles to ensure control of the chair. Ask the patient about their preferred speed to avoid the patient becoming nauseous or dizzy. Check ceiling mirrors before going around corners or crossing busy hallway intersections for oncoming traffic to avoid collisions. If a patient becomes distressed or slides out of the chair, immediately locate a healthcare professional or dial 3 for immediate hospital assistance. Please do not put your own safety at risk trying to lift a patient. Some patient populations have special considerations due to their condition. Patients who have suffered a stroke may have residual weakness on one side of their body. Patients may also have less feeling or awareness on one side of their body. For these reasons, do not pull on the patient's affected arm, as it may be weak and unable to support itself, risking injury. Ensure the patient's affected arm is supported and does not hang from the side of the chair, putting it at risk for getting bumped or caught. The patient may have poor awareness of where their arm is in space. Support the patient's affected foot with a footrest to prevent it from getting caught on the ground or by the wheelchair during the transport. Patients who have had a hip replacement have restrictions on movements they are permitted to perform to preserve the integrity of the newly replaced joint. For these patients, the patient's knees should not be raised above the hip level when sitting, nor should they bend more than 90 degrees. The patient is not to pivot on the operated leg when stepping into a vehicle, nor allow the operated leg to cross midline. This includes crossing their ankles or crossing their knees. Although the patient has been educated on these restrictions, it may be helpful for you to know as well to keep in mind when transporting this patient, as they will not be allowed to cross their legs, bend forward to pick something up, or sit into a low seat in the car. As mentioned earlier, at times your role may include transporting a patient to their car when they're leaving the hospital. When a patient is leaving the hospital, ask the patient or a family member to hang on to heavy bags rather than hanging them on the back of the wheelchair. Back the patient into the elevator to allow easy exit and ensure patient ease at being able to see the route traveled. Transporting a patient for discharge does not include taking a patient to the parking lot, but rather to their awaiting car at the hospital entrance. Here, you can assist the patient and their family by helping position the wheelchair appropriately to allow greater ease for the transfer from the wheelchair into the car. Suggest that the client transfers into the car from the road level rather than the sidewalk, as this will be easier to not have to manage the step down. The front seat is preferable. Have the seat as far back as possible, with the seat in the reclined or upright position. Ensure the brakes are on the wheelchair and footrests have been moved out of the way before the patient stands up. The patient will hold on to the back of the seat and the corner of the dashboard to enter the vehicle, sitting on the edge of the seat and then pivoting both legs into the car. Carefully back the wheelchair away from the car and return the chair to the hospital entrance. If you feel uncomfortable with an assigned task,
no joyriding in the hospitals with the wheelchair, okay? That's the takeaway. Okay, questions about the wheelchair? Anything? About anything you saw?
About the lever?
About the lever. So what should we do with the wheelchair anytime it's at rest?
Break.
Break it. Lock it. Lock those wheels, right? Yep, good job. What kind of things can we pile in the patient's lap?
In theory, nada.
Right. Maybe a blankie covering them up. We really don't want to put anything in their lap, right? So how should we go into an elevator? Backwards. Yep. What about a ramp?
Backing up.
Yeah, backing up on the ramp too, right? Or just hop on the back of the wheelie bar and just ride down with them. Whee! Sounds really fun. Let's see what else. Those are some of the main things I was thinking about. I think an important part is just, like we said previously, just communicating with them everything that you're going to do, and realize that if they've just had surgery or something like that, they could have meds on board, so you might just have to repeat the really simple things a couple times, especially if they're disoriented or, you know, those kinds of things. Okay. Anything else about the wheelchair? Nothing. Okay, next. I think I had one about going over the stretcher, but I think we've pretty much done that already. So I'm not gonna go over that one. This one is the one you might need Dramamine for. And this is the one where transporting a patient on a stretcher. So if you get dizzy, close your eyes, okay?
Hi, today we're going to learn how to transport patients safely through the hallway. After you check the wristband and make sure you got the correct patient, you're going to raise the stretcher to your height so it makes you easier.
I think he's got a little southern accent going on.
Take our brake off, put them in steer mode so you can.
And that thing sounds squeaky.
In the steer mode so we're moving more easily around corners through the hallway.
All right, is it weird to you or is it just me? My eyeball?
We want to make sure we go real slow around corners so we don't run into any oncoming traffic And just so that we don't hit any
It's
walls.
like they're in water.
This time we have a good mirror, so we don't have to really go that slow. We just have to make sure nobody's coming.
It's
And
wavy.
We also want to help patients
It
going over bumps, like all this window. So that they don't get hurt or worried that we're driving bad. Once again, we're going to use our mirror here to go around this corner. We'll see if nobody's there, so we can get that good. Also clear, so we're going to make our way to the elevator. And also, you want to
It
make
is
sure that
raining.
when you get on the elevator, you let your patient know there's going to be a bump, because there's always a bump on the elevator. And we're going to back our patient in head first to the elevator, so that when they come off their feet, they're coming off first.
Okay. So that's that one. All right, get rid of that one. Questions or comments about the gurney? I think we pretty much talked about all the controls on our gurney. Very similar to the wheelchair, entering and exiting the elevator. Any questions about that before we watch the Muppet surgery video? Okay. Muppet surgery.
Hey there, it's my favorite medical student. How's it going? We're back in the OR today. Isn't it great?
Yes.
You got here nice and early, just in time to help us with an important job, transferring the patient. It's something we have to do with every single patient who comes to the OR, but I bet you no one has ever shown you how, right?
Dr. Thumbs.
Okay, stick with me and you'll be an expert at this in no time. Here comes the patient and our team now. First thing is, we bring the patient in on their bed. We put them right next to the operating table, nice and close. We don't move the patient until we're sure the brake is on and the bed isn't going anywhere. Now we help the patient move across by themselves. The table is narrow, so make sure they are in the middle. Now,
So is that blood
take
on
the
the
bed out of-
patient's shoe? That's just gross. Okay, one thing I wanted to say, let's see. I said back it up to this part right here. Okay, so one of the things that if you're helping the patient to move over with a mobile transfer, you would just want to make sure that that gown is not underneath them. So as they move over, one of your jobs, if you're on that far side, is just to kind of grab a hold of that gown and pull it out from underneath them. Another thing that the nurses are like fastidious about is undoing the knots on the gown so that they're not resting on the knots on the gown. And if they can't get the knot undone or the tie or whatever, they will simply cut it with their scissor. So just making sure that they're not all wrapped up in that gown. I just wanted to make that little
middle.
tidbit. Look, bloody
Now,
shoe.
we can take the bed out again.
Gross.
Usually we put it in the corridor until we need it. Now we can get the surgery started. Okay, the surgery is all done, and we're ready to transfer our sleepy patient back to their bed.
Do you notice this girl right here? She is chewing gum. Never, never, never have anything in your mouth in the OR, ever. That's not a good practice.
Remember to make sure the brake is on. We need 6 people in all. 1 at the head, 1 at the foot, 2 by the table, and 2 by the bed. Here's what's going to happen. The patient is lying on a sheet. The team gently rolls the patient away from the bed and put a special rolling device under them. Then, the team gently pushes the patient from the table to the bed, keeping control of the head and the feet. And then, they roll the patient back again to remove the roller and leave the patient on the bed on the sheet. Let's watch again in full speed.
So a couple things here, which this is not really realistic, because if this patient is asleep, they're not going, or sleepy, they're not going to have really control of their arms. So one thing that if you're this girl at the chest, you're going to put the patient's arms, well, this person is over here when they start, put the patient's arms across their chest, and you're going to have one hand on the controlling those arms so that they don't fall. And then once, you know, they get over to the gurney, then this person is going to be, you know, you can either have your body up against the patient like she does here, or one hand, if there's 6 people, there's definitely enough, one hand controlling the arms that are on the, you know, on the abdomen or whatever, so that they don't fall. So controlling the arms is a big part there as well.
And again, from another angle. And again, from another angle. Now, we can
Isn't that
push the bed
burrito?
out of the OR and get ready for the
What didn't they do? What's wrong with this picture right here? Anybody guess?
They didn't put the side rails up.
Right. She's not covered too. That's good too, Tori. And yes, they didn't. So they didn't cover her, and the side rails are not up. So as soon as you move that gurney a little bit away from the OR table, you just want to put those side rails up immediately. Good jobs.
the next case.
Ready for the next case? Okay.
Okay, so I was wondering, like when they would grab that thing, it would kind of burrito and her arm was just at her side. That's not enough to keep that arm in place.
It is just better to be able to have control of them. Yeah, because it could, as she's moving over, it could, you know, go like this across the bed as she's moving that way. And then, you know, just if you have your body up against the patient on the other side, then that is probably enough. But then that gurney is going to be moved away from the table. So just being cognizant, and just so one of those arms doesn't fall, like I would say more precautious than not. Yeah, and sometimes it is enough just to have an awareness of those arms, I think is good practice. What else? Other questions about lateral transfer of immobile patient? So who leads the transfer?
Isn't it the anesthesiologist?
Yes, definitely. Anesthesia care provider is going to lead that. They're going to do 1, 2, 3 count. So we will practice that when we're in the lab starting tomorrow, and then on Thursday with our other group. Let's see if there was anything else. And, you know, probably you can get away with 4 people if it's like a patient that size. But if it's a larger patient, you want to make sure that you have more people. And in a lot of places where I've worked, especially the surgery center, we'll have to yell for feet help. And so we'd be ready to move the patient, and we would be like, is someone available to get the feet? Especially if you don't have a 4th person in there, you know, if it's just the anesthesia care provider, the nurse, and yourself, then you definitely need a 4th person for that immobile transfer. Yes, we're going to use the roller board, Tammy. We have that. We will use that. And there was kind of like that pad that was underneath the patient. We're just going to use a sheet. A lot of times in the OR, we just put a sheet like across the bed. We call it a draw sheet. and it kind of gets positioned where it would theoretically be under the patient, like shoulders to buttocks, kind of. And then that will help us to, you know, do the burrito for the patient. Okay. Yep. Other questions about that? It'll be fun. Doing transfers is fun. Okay, then I think I have one more video. And this one is just about the OR table, because we are going to be doing positioning, and you guys are going to give us some more information on that. But I thought we would just look at the table quickly. This is just a couple minutes. But we'll also play with the OR table once we're in there. It has a remote, and so I'll show you guys how to use the remote, what the buttons mean, and typically, if we need the bed adjusted intraoperatively, that remote is typically up by the head, so anesthesia can just adjust it for us a lot of times. Okay, let's take a look at that.
The operating table is used for most operative procedures. It can be configured into many positions and accommodates accessories for different types of surgery. The frame is stainless steel and attaches to a hydraulic lift. The handheld remote control unit allows the anesthesia care provider to change the position of the table at any time. The headboard and footboard can be flexed or removed. The kidney rest can be elevated to raise the flank and offer wide exposure. The perineal cutout allows unrestricted access when the patient is in the lithotomy position. The standard arm board is used when the patient's arms are outstretched. At least one arm is abducted during surgery to create access to IV and monitoring site. The arm is secured by means of a padded strap, semi-rigid brace, or rigid cradle. Stirrups are used to elevate and abduct the legs for access to the perineal area. The type of stirrups used depends on the procedure, the surgeon's
So that first stirrup, let me just go back to that really quickly. This stirrup right here is called the candy cane stirrup. And he's only putting one on because the patient's going to come in on this side. So we wait to put the second one on until the patient is in and asleep and those kinds of things. And this is not going to be down before the patient comes in the room. The bed's going to be in its normal orientation so that the patient can scoot over there and be put to sleep. And then once they're asleep, then the legs will go up. And we'll practice lithotomy positioning as well, just not in this course. Okay, so that's the candy cane. And then the next one is called the Allen stirrups. Okay, let's look at that one.
The type of stirrups used depends on the procedure, the surgeon's preference, and the patient's physiologic tolerance for the position. All necessary equipment must be assembled ahead of time.
So those are like little
Padding,
boots.
pillows, positioning devices, table accessories, and transfer devices must be on hand before positioning begins.
Okay, that's just a little snippet. Okay. So besides those stirrups, there's so many different types of positioning devices. And there's also different tables as well. So as we go through the different specialties, when we talk about orthopedics, we'll look at what we call the beach chair. And if you can think of like sitting on, like lounging on a chair next to the beach, it kind of puts the patient in that semi-Fowler's sitting position with access to the shoulder. And there's fracture tables, spine tables and positioning devices, different things. So as we go through the different specialties, we'll definitely look at those a lot more closely, okay? So we'll learn more about those as we go, but not all at once so that it's not so overwhelming, okay? All right, questions about anything so far? Nothing? Okay, so let me talk about our activity. Here, let's see. I think I need to make this shareable because I don't think I did that. And then that way you guys can access this if you need to. Let's see. Okay, anyone in the link with the link can view. Okay, so I'm going to break you up into 3 groups, like I said, and you're each going to be assigned a position. We're looking at supine, lateral, and prone. Those are the positions we're going to be looking at. Now, I know the book goes over more, and we will do that on Wednesday, but here specifically for the sake of our lab coming up this week, I want to look at those 3, okay? So you're going to make a little mini presentation, and however you want to put it together is fine with me. However you want to divvy up the work, you know, if you each want to do a slide and talk about the slide when the time comes, whatever the case may be. These are the components, okay? So for your assigned position, you want to find an image of the position, and then indicate the number of people that are going to be needed for that positioning, a list of equipment, and if you could find some images without too much trouble, that would be fantastic. Identify some of the risks associated with the position, and then maybe some safety considerations as well. I think those 2 kind of go hand in hand. The types of procedures associated with the position. So if we were doing lithotomy, let's say, which we're not today, but if we were, then some procedures that could be completed in the lithotomy position would be hemorrhoidectomy, D&C, vaginal hysterectomy, those kinds of things. So just, it doesn't have to be a comprehensive list, but you know, list some procedures and then a brief kind of canned soup step-by-step instructions for the positioning. And you can get help with that in the textbook as well. I think that starts on around page 361, and then it goes through the various positions. So supine is there, lateral is there, prone is there, so that can help you with the step-by-steps as well, as you're kind of putting this together. Okay? Questions? I'm going to grab the link so I can share it with you just in case you need to revisit this as you go along. I'm gonna put it in there. Okay. Do you guys want a break before we start this? I know it's a little bit early, but do you want to take your break now or after you complete the activity and before you present? We can do it either way. Don't care? After? Okay. All right. I know it's a little bit early. So let me put you in your little groups. We're going to do 3 groups because there's 3 topics. All right. Once you get, I'm not going to tell you, oh, well, I guess I should. I'll just go by the first person in the group and you'll know what topic, and then you guys can decide who's going to do what. Okay. So, Ariana, you're in room 1 and you guys will take supine. Adriana, you're in group 2 and you'll take lateral. And then group 3, Alexis, you guys have prone. Okay, so I'm going to give you about 15 minutes and then I'll kind of jump around and see how you guys are doing with this, okay? Questions before I send you off? Okay, text me if you need something. Otherwise, I will see you in about 15, okay? Okay, here we go. Okay. We are going to see what you found, what you found out. So my first group had supine. So who wants to share their screen? Who is going to share their screen for group 1 supine?
I guess I can.
Okay. Okay. Ready.
And we didn't really talk about how we're gonna do this, so
And we could just do our own slides, I guess.
yeah. All right, so yeah, ours is
So-
supine.
Mm-hmm. So, this is pretty much the description of it and a beautiful picture. So we have the supine position means lying horizontally with the face and torso facing up as opposed to facing down. It is the most common position used in the operating room.
And the number of people required for transfer is 2 to 6 people. And it is dependent on the size of the patient and the staff, which is moving the patient, the ambulatory status of the patient, meaning whether they are awake and mobile, whether they're severely ill, medicated, and drowsy, and so whether they can help or not.
All right, so we had a couple equipments here. We have by the head, we have the gel donut. Behind the back, we have the gel torso surface overlay. Above the elbows, we have the gel ulnar nerve protector. By the arms, we have the gel armboard pads. And under the pads, we have the arm cradles. In the mid, by about 2 inches above the knees, we have the table strap. Then under the knees, we have the gel dome positioner. Under the heels, gel heel cups. And then under the hand and the wrist, we have the A-line support splint.
So some of the associated risks, if the patient is left in that position for too long, could be skin breakdown, lumbar strains, nerve injury, and then just issues with the circulatory and the respiratory systems.
Okay, so safety concerns. So because of this position, there's extra pressure on bony prominences. And then because of that, we need to take care of nerve injuries. So that's what those supports go ahead and do. Those gel pads go ahead and support those bony prominences to prevent like peripheral nerve damage, ulnar, and brachial plexus nerve damage.
Some of the procedures associated with the supine position are intracranial, cardiac, abdominal, so the lower extremities such as the hip, the ankle, the foot, and the knee. That's also ENT, so ears, nose, and throat, and then neck and face. Good.
And step by step for the supine position. So that patient is carefully transferred using 2 to 4 helpers. Patient is faced up and head is supported by the donut pads. The arms are tucked near torso and secured with arm guards or flexed across body or extended and secured on padded arm boards. Safety strap is implemented after positioning at 2 inches from the knee. Extra padding is placed under patient's knees and feet if necessary. And pregnant women need to be positioned with care to prevent uterine compression against the vena cava. And a pad will need to be placed under the right flank.
Good.
And that's it.
Okay, awesome.
Ta-da.
What questions do you guys have about supine positioning? Anything? A couple things that I thought of as you guys were kind of talking through that was as far as positioning devices like arm cradles or arm boards or whatever, it just depends on like surgeon's preference and what we're doing. So sometimes surgeons might want the arms, what they call tucked at the sides. So they're going to put the arms straight down to the patient's sides, and they're going to use these little slides that kind of hold and protect the arms. They might put a little gel pad or some kind of foam pad in there and slide those under the OR table pad, like between the table and the pad itself, and the arms will be down at the sides. Other times they'll both be out on arm boards, and we just want to make sure that that's less than 90 degrees so that we don't damage the brachial plexus or injure it in any way. And then we want the palms turned slightly inwards, that if we put the arms so that the hand is like this, the patient's going to be resting on that ulnar nerve there at the elbow. All right, so if we turn the palms in just a little bit towards the patient's body, it takes some of that pressure off the ulnar nerves. Okay, instead of using gel pads, sometimes, have you guys seen like that foamy like egg crate stuff that has like the little bumps on it? Sometimes they'll use those under arms and under heels. All right, and another thing that we want to make sure of is when we have them move over to the table, when they get laid flat on their back, a lot of times they want to cross their ankles or, cross their feet. And we just want to be cognizant of that. And if we notice that, just kindly and gently help them to uncross their feet and just remind them that we don't want them crossed because that could put pressure on the back of the ankle there. All right. Something else we have to think of when we're positioning patients when they can't move themselves is something called shearing. So shearing happens when the patient moves this way and the sheet moves that way, or whatever they're laying on, right? So that could damage the skin integrity. So that's something else we want to be really careful of. And then lastly, you know, your list of procedures was great. The only other thing I thought of was we can also work on hands and arms, upper extremities in that supine position as well. Lots of different surgeries in the supine position. It's a fairly common position. Okay, good job. Any other questions or thoughts about supine? Round of applause. Okay, good job. All right, let's talk about lateral position then. Who is going to do the honors?
I can share.
Okay, thanks, Wendy. All right, you're good to go.
Okay. So, sorry, I'm having trouble here. Alrighty, so we got lateral. So in this position, the patient lies on his or her side for exposure to the lateral chest and flank. The patient is maintained in the position with a combination of table accessories and padding, with both arms slightly flexed and extended and no greater than 90 degrees on padded arm cradles or holders.
The people needed for this position, it depends on the patient's weight, physical condition, and level of consciousness, usually about 4 to 6 people.
So positioning equipment, we need gel pads, we need positioning aids, head support for a hollow form of pad, 2 arm boards, and a bean bags. And these are just examples. Like, I try to find best pictures I could that shows like details into it. Okay, thank you.
Thanks.
The associated risks with the lateral position is airway obstruction, spine torsion injury if the patient is moved without stabilizing the head and keeping the cervical spine in line, corneal damage to their eye, nerve and vessel damage in feet, and nerve damage in the brachial axis, which is the reason for the axilla gel pad to be placed right below it.
So careful attention must be paid to the arm positioning and be sure to evaluate throughout the procedure. Careful on that down eye to avoid external pressure, as well as that down ear to avoid bending or ischemia. An auxiliary roll must be placed between the chest wall and operating room table to avoid compression on the axillary vessels or the brachial plexus. You also want to make sure all pressure points are padded, and careful attention to any IV access, invasive monitoring devices, and the endotracheal tube to avoid accidental removal.
Good.
The types of procedures, jackknife positions. And, you see on the picture right there is doing a leg surgery.
Okay, so step by step, the patient's dependent leg should be flexed at the hip and knee. Next, the upper leg should be straight and supported with an approved positioner between the legs. Next, the dependent knee, ankle, and foot should be padded. And lastly, support should not press against the abdomen to avoid impairing venous drainage from the lower limbs.
Okay. Nice. Questions, comments about lateral? Couple things I thought about as you were going through your presentation. Great job, by the way. When the patient, okay, so let's say the position is left lateral. What does that mean specifically? Who can tell me?
That the left is a non-operative?
Right. So left is going to be against the table. The patient's going to be on their left, right? Or the patient's going to be on their right. So if we're doing a right nephrectomy, then we're going to use left lateral. Does that make sense? It's an important thing. Sometimes it seems confusing, but remember that whatever the position is, left or right, it means they're going to be laying on that left or right. Okay, so just wanted to clarify that. Sometimes they'll use a bunch of pillows between the arms and between the legs. I have seen them use tape to go around the arms and to go around the body. They literally go underneath the OR table, up over the patient, underneath the OR table, up over the patient. So you might see that. Sometimes the strap is not long enough to get over that patient when they're up on their side. Sometimes they'll use a beanbag positioning device that is roughly a little bit longer than the length of the torso, I would say. So that would go on the bed with a sheet over it before the patient actually moved on to the bed. And then once the patient is up on their side, and we're doing this when they're asleep. So that's why it takes quite a few people to, you're gonna have to lift the patient up, slide them more to one side, and then roll them up on their side, right? And once they're up on their side, if we're using that bean bag, there's the nurse will be prepared, hopefully already, with a suction tubing and a little adapter called a like a 5-in-1 connector, but it's just like round and it's tapers on each end, and we'll mold that little bean bag up around the patient and then hook a suction to it, and it's going to suck out all the air and it's going to make it like hard, so that it supports the patient. One thing we want to think about is where that down leg is pressing against that bean bag. We want to pad that area really well as well. There's also another device they sometimes use called a pegboard, and it's a big plastic board that has holes in it, and you put a gel pad on the top of it. Once the patient is asleep, you do the same thing, put the gel pad up around them, and there's these big posts that go in the pegboard in front of the patient and behind the patient to keep them in place, which for total hips is used quite frequently. Let's see, something else that we need to check during positioning is the breasts and the testicles. Okay, we want to make sure, like with the males laying in the lateral position, if the testicles or the penis are between the legs, that could cause damage. So somebody has to check that, all right, to make sure that's okay. And then Sometimes with these extreme positions, you mentioned corneal abrasions. And so anesthesia has these cool little, they look like a mask almost, but they're adhesive back. And they have like little plastic bubbles over the eyeballs, and the rest of it is foam, and they will just adhere that to the patient's face so that that will protect their eyeballs. Yes, Ian, you're absolutely right. All of those things must be checked. Rifle through their wallet for sure. Okay. I think those are all the thoughts that I had about that. Questions about that?
How many injuries had to occur in all of these positions to come up with all of this equipment? You know? I mean,
yeah.
It's kind of daunting to think about, you know. I don't know. I guess I'm glad it's there now.
Yeah, sometimes the longer a patient is in one of these extreme positions, no matter how we pad them, no matter how much care we take, the longer they're in these positions, the higher their risk becomes. Like when I had my hip replaced, it was a 3-hour tour, which is not typical for a primary hip replacement. But I have like neuropathy in my left hip, and every once in a while it'll like feel tingly like down my leg. I know that's what it's from. Like being on that hard board up on my left side for 3 hours, like it's just inevitable. I think some tissue damage. So yeah, and usually something isn't invented until something goes wrong, right? And then we're like, oh yeah, well, I guess we need some sort of device for that. So yeah.
In a long procedure like that, would a surgeon potentially say, this patient's been in this position for a really long time, let's adjust them a little bit to, you know, maybe prevent any sort of nerve damage, or it just is what it is?
Yeah, not that I've ever experienced. The only thing that I can think of that comes to mind when you ask that is with the tourniquet, the pneumatic tourniquet. It can only be up for so long before there's a risk of like ischemia, you know, so we use like, it looks like a blood pressure cuff, but the PSI is like 250 or between 150 and 250, depending on if we're putting it on an arm or a leg. And at 60 minutes, if we're still working and the tourniquet has been up for 60 minutes, they'll typically put the tourniquet down and wait 5 minutes and then reinflate. But that's, you know, that's the only situation. I haven't ever been in a case where they were like, it's been 12 hours, let's, you know, reposition the patient, or, you know, or anything like that. I guess if there's some sort of double procedure that we're doing, then there might be a situation where we're either repositioning or we can check the patient in between. But, you know, there's really typically only one way to be able to gain access to wherever we're working. Yeah, and so I think that it's a good segue into saying that whatever we can do as surge techs to facilitate the procedure and shorten that length of time, like we can really make a difference in how long the patient is under anesthesia. You know, not in every instance. Sometimes you just have difficult procedures that take a long time, and that is just the way that it is. But there are definitely things we can do to facilitate it, to shave some of those minutes off. Yeah, good questions. Other questions? No yawning, Ian. Stop that. Okay, let's talk about prone then. Who is going to run the controls for our last?
I suppose I can do it.
Okay, thanks, Ian. Let me see here. Okay, you are the host.
Okay. One moment.
Standing by.
Share screen. Oh, there it is. Loading. Loading. The prone position.
So 4 to 6 people are required to turn the patient from the gurney to the operating table. A hydraulic lift may be used to elevate and turn the patient around. So this is the prone position.
As far as positioning equipment, we've got our regular safety straps, and one of them is going to go about 2 to 3 inches above the back of the knee when they're laying face down. And then we also have ones that may need to secure the arms as well. There are going to be foam or gel chest lifts that are going to run from the clavicle to the iliac crest. And then in female patients, we want to make sure there's a hollowed out form, so we're not squishing the breast. And then as far as the male patients, that's something to be considered as well. We want to make sure that the genitalia area is protected and things aren't being pinched and smashed where they shouldn't be to prevent impingement. And then also the arm pads and let me go back to the prone head pad. So the patient's going to be laying face down, so that's going to be that open area there. And sometimes the anesthesiologist will also use a mirror if he needs to view the patient's face while they're under anesthesia, so that helps allow him to do that. Those arm cradles, arm pads or cradles that you see, that is the egg crate type that Ms. Windsor was discussing. And when the patient's being positioned, the arms should be at no greater than a 90-degree angle. And then we're also going to want to make sure that there's pillows for the legs and the ankle area to make sure that those toes aren't pressed down on the bed and creating issues in that direction as well. Beauty. Anything else? I think that is about it for me.
Good, thank you.
And then the risks, head and neck pressure sores, chest pressure sores, cardiovascular collapse or arrest, injury to central nervous system, changes in respiratory, injury to peripheral nerve system, and then embolic complications.
Good.
Some safety considerations. The patient typically will be anesthetized and intubated while in the supine position prior to transferring to the prone position. So it is important to protect and maintain the airway during this transition, as well as maintaining the rigidity of the spine, so proper control of the head. There will also be additional pressure on the abdomen and chest that can restrict normal ventilation. In addition, it is important to maintain the airway at all times throughout the procedure. Typically, the patient's head will be in a hollow-centered foam rest to allow the anesthesia provider access to the patient's airway at all times. There must never be impingement of the axilla nor on the genitalia, specifically for men. And there is additional risk to the eyes and neck structures based on the position itself.
Good.
Types of procedures associated with the prone position.
So spinal surgery could be done in the prone position. It could involve all sections of the spine and the posterior of the neck as well, and the brain, so neurosurgery, and colorectal surgery. And I believe that's in the jackknife position. It's also called like Kraske position.
You got it.
And also the lower extremities of the leg, like the back portion of the leg as well. I'm assuming that this lower left picture is done for like neck and like for the back, for neurosurgery of the posterior portion of the brain.
Yep.
I'm guessing. And these are pictures I found as well. And I'm done.
Thank you.
Mhm.
So step-by-step instructions. So first, ensure you have the proper number of people. The patient is like flat in neutral position with a side sheet beneath them. They do like a horizontal move, and then like they turn them like laterally, then supporting the head and the feet. They center the patient on their abdomen and remove the side sheet. They position arms in a swimmer's position, and then yeah.
Good.
That's it.
Awesome. Thank you. Questions or comments about prone? Good job with your presentation. A couple things that I thought of as you were going through, you mentioned that the patient will be anesthetized supine before they are put into the prone position. A lot of times anesthesia will feel more comfortable intubating the patient on the gurney. So if that's the case, you'll unlock the OR table, somebody will, and move that out of the way, and the gurney will kind of go into that space. And then anesthesia can put the patient under general anesthesia right on the gurney, and then once that happens, gurney can get moved over a little bit, OR table goes back into position and locked, and then it's like a log roll from the gurney to the OR table, which is easier than putting them on the OR table, scooting them, and turning them. So before we do that, we want to make sure that those chest rolls are in place, that you saw those kind of long cylindrical, either gel or like the long pillows that you have to go under your neck-ish. So whoever is going to be catching at the chest and at the abdomen, they're going to lay their arms like this across the OR table. So one person is going to be at the chest over those arm rolls. Another person is going to be lower down, kind of abdomen, groin area. And two people on the other side are going to push, roll that patient over, and those other two people are going to catch. And then at some point, you have to try to figure out how to get your arms out from underneath them. The breasts, if it's a female, need to go between those chest rolls. So they need to be far apart enough so that the breasts are comfortable between the chest rolls. With males, that's not as significant, but you mentioned the groin area needs to be checked. When we move the arms, so when the patient lands in the prone position, their arms are going to be down by their sides, and you want to make sure that and we'll do this with the mannequin, you can't just pull their arms straight up like this. You have to kind of bring it around and up, right? So the patient's going to end up this way. So just really careful moving those arms, making sure that they don't fall off the table, right? Because the patient's asleep. So having an awareness of that. Oh, and then one procedure I thought of on the lower leg that can be performed in Prone is Achilles tendon repair. That's one that I thought of, that we typically put the patient in prone to fix that Achilles tendon. Yeah, those are the big things that I thought of. Good job, everyone. Questions or comments about any of these things that we talked about? We'll be doing them this week, so hopefully that'll be that last component. That'll kind of make everything make sense. We will not be positioning each other. We will just be positioning shim, okay? But we will take some brave volunteers to do lateral transfer. However, if nobody feels comfortable with that, we can use the mannequin, okay? I'm okay either way. Whatever you guys feel comfortable with, we can figure that out as we go, okay? Let's see, what else? Anything else on that? Okay.
Instead of like, you know, putting the patient to sleep, I think it would be easier if the patient was awake and they could just like maneuver themselves. So yeah, I was just like, oh. What if, do they have that option, like just to be awake and like position themselves?
If they're not having general anesthesia, we will ask them to do that. Yeah. So, but if they're having general anesthesia, it's really hard to intubate a patient when they're not in the supine position. That could be really difficult for the anesthesia care provider. It could damage things, anatomy of the patient. So if they're going to have general anesthesia, they're going to do that, and then we're going to position. But if the patient's having a local or they had a spinal anesthetic, we'll ask them to get into position where they feel comfy before either the spinal anesthetic completely takes effect or, you know, before we inject local anesthetic. Yep, that's so much easier. Did I tell you my horror story about Frank? Did I tell you? So Frank was, he was a larger individual. He needed a hemorrhoidectomy. And he didn't want general anesthesia, and anesthesia didn't want to give him general anesthesia because he was at high risk. So they decided on a spinal anesthetic. So one of the things that the anesthesia care provider takes into consideration with the spinal is that it needs a few minutes to set. Because if you give a spinal anesthetic and then you put the patient in like a head down position, and Tolman mentioned the Kraske position or the jackknife position, that head down, feet down, you know, with the buttocks up at the top like this at the apex. So if you don't wait long enough for that spinal to set and you put the patient this way or this way, that spinal can travel because of gravity. All right. And if it travels too high, what does it paralyze? The respiratory system, right? The phrenic nerve can't breathe. Okay. So, we did the spinal, we waited a few minutes, anesthesia said everything was okay. Frank actually moved himself over, got himself comfortable, and then a few minutes later, put him into the jackknife position. You know, there's other things that we have to do in that position, like we take tape and we literally tape it to the buttocks, like each butt cheek, and then tape it like to the bed rails so that it provides exposure, all right, to the area that we're working on. And so after all of this was done and we get prepped and get draped and everything and we start working, and anesthesia is like, so Frank, how are you doing? Frank said, fine. Okay. So we get started. Couple minutes later, anesthesia's asking Frank again how he's doing. Frank doesn't respond. He's like, Frank, how are you doing? No response. So Frank was not breathing, hadn't been breathing for a couple minutes. So we had to stop our surgery, bring the gurney in, roll him back over onto his back, intubate, and then Frank got to spend quite a few days in ICU where Frank was never the same after that. I was like permanent, sustained permanent brain damage because of that. So, anyways, I don't know. There's no moral to the story, I guess, except for just a hyper awareness. You know, it's not really our responsibility to make sure that, you know, anesthesia is doing what they're supposed to do. But as a patient advocate and as those extra eyes and ears, it's important to have an awareness that when a patient does have a spinal and they're put in that head down position, that they could go into respiratory arrest. That's a possibility, all right? If the spinal hasn't set, right? If there hasn't been enough time and, you know, so anyways, learn from my experiences, like I said before. Okay, now after that sad story, we're gonna look at some plastics instruments. Okay. There's 25 plastics instruments. Oh, I haven't put in your corrections yet. If you sent them to me, I will do that after class today, okay? Let me get the chat out here so I can see, you chatting. Now, this is interesting because don't get mad at me. We're going to have scissors and needle holders that look pretty much the same. Don't get mad. Okay. Having said that, our first one here, I don't know if you guys have been looking at these yet. I did give a heads up that plastics was coming. There's a couple things that you should already know in here, but this very first one that you're looking at, a couple things I want you to take notice of. One, how cut in the very tips of these scissors are. Very good for fine dissection of things, all right? This is called a Jamison scissor, and a Jamison is typically, you're gonna see another one called a Stevens tenotomy. The Jamison is usually longer, like a 6-inch length, where regular tenotomy scissors are a 3-inch length, maybe 4-inch length. But basically they look the same at the tips, and whether or not the surgeon uses one over the other is probably their preference. I had a surgeon that liked what he called the 6-inch tenotomy, which was a Jamison scissor, but he knew it as the 6-inch tenotomy. So anyways, so cutting and dissecting, you can see that cut in tip right there, different than any other scissors that we've seen before. So this guy right here is called the Iris scissor. Let me show you how it's spelled, Iris scissor. Okay, good for cutting and dissecting. It's a very small scissor, about 3 inches in length. And what distinguishes the tenotomy or the Jamison from this one is that it doesn't have a severe cut in tip. It's a gradual taper to a very sharp tipped scissor. Okay, again, surgeon's preference. There's also straight iris in addition to curved iris. This one here, let's take a look at him. Does this crack you up, the littler plastic surgery scissor? It's littler than all the rest. I don't know, littler than what? The Metz? It pretty much looks like a Metzenbaum scissor, but it's going to be shorter. Okay. This guy, let's look at his name, the caudal tenaculum, double caudal tenaculum. It's retracting, handheld retractor, and it looks a lot like a double skin hook. This handle is kind of specific to the caudal tenaculum. We'll see a single one as well coming up here in a bit. Surgeons like these for plastic surgeons when they're doing, sometimes when they're doing blepharoplasties, or even if they're doing mastopexies like breast lifts, things like that. Basically, this is going to go into the skin, like it's going to be retracting the skin or the very superficial layers. So this is called the mesher, or I think the book calls it derma mesher. Derma mesher. And this is an interesting device because when we take a skin graft, we can increase its surface size by putting it through a device such as this. It will go on a little plastic card, and that's a disposable part, and it has little lines, and we'll put the skin on there, and then the surgeon will move this little handle back and forth, back and forth, back and forth, or sometimes the handle goes all the way around. And there's a big drum right here. It's kind of like a ringer washer from the old days. But it's going to cut a little mesh-like pattern in that skin graft, and it's going to allow us to increase the surface size up to 3 times of whatever the skin graft is that we took. So that's the derma mesher, or the mesher. And we'll see the dermatome coming up here in a bit. What type of instrument is this? We've seen other guys that kind of look like this.
Is it a needle holder?
Yeah, it's a needle holder. For suturing, this is a little guy. He's called the Halsey needle holder. And the Halsey needle holder is about 5 inches in length. And you can't see in here, but it has little ridges inside here. So that's an important distinguisher between it and what I'm going to show you is the Webster needle holder. Okay, so the Halsey has these little ridges inside its jaw, if we were to look in there. Probably the surgeon's going to call it a Webster. I've only had one surgeon that nothing I gave him was a Webster. He wanted a Webster, but nothing I gave him was a Webster. So apparently I didn't know what a Webster needle holder was, or maybe he didn't. This is the single skin hook. Okay, it's called the Joseph single skin hook. Retracting and exposing, again, for retracting skin predominantly. The Joseph. Next, this is the dermatome. So this is air powered. So this long hose is going to get passed off to the circulator. It's going to get plugged into the wall or wherever the receptacle is that this would get plugged into. The nurse is going to plug that in. And what we have to do is, if we were to flip this guy over, first of all, let me talk about this little switch. There's a little switch here, and in one position, it is in the safe mode, and then in the other position, it is in the go mode. Okay, so we always want to make sure that it's in the safety mode. This right here changes the depth of the skin graft. Okay, so this is like a air-powered skin cheese grater. Okay, it's going to slice off some skin for split thickness skin graft. So this needs to be set on 0. That's what the surg tech does. Then the surgeon can set the depth himself or herself, but start this at 0. If we were to flip this over, you would see where the blade would fit in there. So the blade, this is the blade, it's a disposable part, okay? 1 blade per customer, and then into the sharps. The blade will fit in there, and then we need to ask the surgeon which size of plate, because can you see this little cutout right here? This is going to determine the width of the graft. All right, so the surgeon's going to tell us that. And then there's a little screwdriver, and this little screwdriver, this fits over 2 little screws that are on the back side. We're going to screw that down. Okay, and then it's ready to go. So this is the dermatome, and it's powered one. Want to see how it's spelled? Dermatome. Okay, cutting and dissecting. And then after we get that graft, that's when we could put it through the mesher, if the surgeon so chooses. Okay, this guy is the Webster. Remember I told you that the Halsey has ridges on the inside, but the Webster characteristically is smooth on the inside. Okay, it's the little guy. Remember the show Webster? Okay, he was a little guy. All right, this is the double skin hook. Notice that the double skin hook, I think it's a Joseph. Yeah, Joseph double skin hook has this round handle, where that Cottle one had the flat handle and is a little bit more robust, a little bit more beefy at the end, if you will. Okay. So this guy is called the mammoplasty hook. Right? And one of these at each corner of an incision works really nicely to be able to pull those skin edges together. So if we were to hook it at the end of each corner of the incision, it would align that, that incision really nicely so that they could close it. But again, similar job as the skin hook, but it's heavier. Okay, those little Joseph skin hooks, they can be bent really easily. So this is a little bit heftier. Just a couple more to go. So this one is the facelift scissor. Now, it's kind of difficult to see, but a lot of times the way you tell the facelift scissor is it has this little ridge that runs along the blade here, but it's kind of difficult to see. This is a lot similar to a Metz. And we know what this is. What's this one?
It's Mr. Sen.
It is a Mr. Sen. Very good. Mr. Sen's. This is the tenotomy scissor. Okay, it's called Stevens. Oh, I lied. Oh, this is the Reynolds. Okay, similar to tenotomy scissor. This one's called the Reynolds. I apologize. I don't think I looked up how long the Reynolds was. Again, a lot similar to the tenotomy. You see how it has this cut in. I'm going to be willing to bet the surgeon's just going to ask for a tenotomy, and you're going to give them one of these. This is called a Meyerding. Let me show you how it's spelled. Meyerding finger retractor. There are also bigger Meyerdings that we use in orthopedics. They're quite a bit larger. Again, a handheld retractor, the Meyerding. It will be too difficult to tell those scissors apart on a test, so don't have anxiety about that, okay? This is the dermatome blade, all right? And this is just demonstrating that it will align with this little screw that's in the back of the dermatome. It is disposable, member, and they're just one size. Do you guys remember what this one is? Didn't we have this one before? Anybody remember? Going once, going twice. I thought we had it. This is called the Jarrett. Remember he went to Jarrett? We're going over something. I can't remember what. Handheld, right? Or I mean, self-retaining. self-retaining. I've also heard this called by a different name, a Heiss retractor, but Jarrett is its name in the book. Good for little finger procedures, wrist, hand, those kinds of things. So this is a handheld skin knife. So different from the powered dermatome, this has a disposable blade as well. It loads right into here, okay? So this is the handheld one. Watson Skin Graft Knife. Watson. Okay. Ian, I've never seen a surgeon use a handheld one. Not to say that they don't, but I think it's difficult just because it's hard to control and get like an even pressure and an even depth. So I would say the Watson may be more useful just for cleaning up an area where a graft is going to go. Does that make sense? Like for debridement purposes almost. Good question. So this guy is the single coddle. The single coddle, remember we had the double coddle with that flat retractor handle. This one has a flat retractor handle as well. So one way we can distinguish it from the Joseph single skin hook. And also it has this more of a right angle. See it there? Instead of the little curve of the Joseph. This one is called the Ragnell. Let me show you how to spell it. Ragnell. Rag with a nell at the end. Kind of looks similar to the Sind, except for it has a little baby right angle end where the rake would be, and then a little bit longer right angle end. This is pretty standard in any plastic set that you'll have. The Ragnell handheld retractor. This is called a mammoplasty retractor. This is actually also really helpful when we're doing augmentations. So breast augmentations. One of the things that they're gonna do with a breast augmentation is create a pocket to receive the implant. And so this is a good retractor for that. However, they also have retractors that have the ability near the handle to attach a light cord, and then the light will shine out the end because it's pretty dark in that pocket, and they're cauterizing and trying to either dissect the adipose off the pectoralis major. And so that extra little bit of illumination helps them out. But mammoplasty retractor. It kind of looks a little bit like a deaver on the end. All right, this is called the keyhole. And what the keyhole is for this goes around the areola. So let's say we're doing a breast lift, which is called a mastopexy. For a breast lift, they're gonna skin the breast. Now, not the whole thing, but they are going to take away some of that skin of the breast, and then they're going to sew those edges back together, and that's going to lift and tighten and pull the breast up. Okay, so the diagnosis for a mastopexy is what we call ptosis, and ptosis is drooping, right? And so, you know, gravity helps out the plastic surgeon, let's say. So this is going to be laid over the areola with the nipple in the center, and when they do a mastopexy, the first thing they're gonna do is use their marker and trace around this, and that's where their incision is gonna be made around the areola, and they'll trace down around this whole thing. the keyhole. Here, let me show you. McKissick keyhole. If you're doing breast surgery, this is a must-have. Now, next, something very interesting. Anybody know what these are by any chance? It's a pretty common plastics procedure that we hear of. Yep, you got it, Ian. So these are liposuction cannulas, and they come in all different sizes. A couple things when we're doing lipo procedures, there's a couple different ways they do liposuction. This is the old-fashioned way that takes a lot of elbow grease from the surgeon because they have to manually like jab this, for lack of a better word. It's very brutal liposuction into the patient's adipose tissue. And that breaks apart the adipose and it gets suctioned out. Okay, these, yeah, don't try it at home, please. Yeah, no. I did hear a story once about some surgeon went to a hotel room and did liposuction on like a patient's buttocks or something. I think she ended up dying later. So don't let a surgeon do this to you in a hotel either. These, because it has such a small little opening, they do have a tendency to get clogged. So it's nice to have a big bucket of water and either a Toomey syringe or that big syringe that has like the thumb thing on the back, or an Asepto that you can just stick the tip in the back end and flush them out as the surgeon gives them back to you. So that's one thing that is a consideration for us. Another thing is just a learning experience for you so that you don't have to go through what I went through when I picked it up by this working end and the surgeon chewed my head off. Okay, so don't handle it by this working end, handle it by the handle, okay? Because these can get bent, the more delicate ones. Anyways, don't be like me, okay? This one is the Stevens tenotomy scissor. Okay, typically about 3 inches in length. Again, tenotomy is you can tell that this one is got a shorter little tapered tip than the Reynolds. And then last but not least, this is called the areola marker. Again, kind of a similar purpose as the keyhole, but this allows the surgeon to determine, and these come in different sizes. So you'll have a variety of them, unless your surgeon just always uses the same size. It has little ridges on the bottom here. Maybe you can see those little lines. But again, the nipple is going to be put centered in this opening here, and the surgeon's going to press it down onto the skin, and then when he or she takes it away, it's going to leave an imprint, and then that's going to be their initial incision. If they're doing a mastopexy or a breast reduction or something like that, the one consideration for the surg tech during this is when the surgeon does make his incision, or she, your job is going to be to flatten out the breast, like to the best of your ability. So typically 2 hands flat down on like around the areola and kind of pushing and pulling out on the skin so that the surgeon can make that very precise incision around the areola. Okay, and that is our tour through the plastics instruments. So you guys have access to that. You can review these. Again, don't be too scared about the scissors because those are really difficult to distinguish in an instrument exam. So we won't be looking at pictures of those on a test. Questions? Are you guys still with me? Are you still awake?
If we do, there's a foolproof way. All you got to do is close your eyes and just pick one.
Do you do eeny, meeny, miny, mo, or
No, I just close my eyes.
you just close your eyes? How do you know you're clicking in the right area?
You know, you just got to hope for the best. If you hit the X, oh well, you know.
If you hit submit,
If you hit submit, you know, the deed has been done. You know, you just go with the flow.
there's no going back after that point.
It's so true.
All right. Any questions about that? Do you guys want to watch some sort of breast surgery before we go? Okay. Do you want a break first? Yeah. Yeah. Okay. Let's take 10 minutes. Let's see. It's 10:24, so maybe 10:35. And then that'll give me some time to pull up a couple videos. Poor kitty. Okay, here we go. Oh, here, let me do this first. I'm gonna turn it down a little bit just so, because it doesn't have any words, so I can kind of describe some things going on here. Okay, she loses her tattoo in all of this. Maybe this is why she's having it done. Probably not. Okay, so this, so you can identify this right here, right? What's that? Yep, no more tramp stamp. Not a Gelpie. Good guess though.
Penetrating
Clamp.
Towel clamp?
Yeah, good job. That's a towel clamp. And there's 2 surgeons working here, obviously. They each got wielding a Bovie, but this is a special Bovie tip called a Colorado tip. It's a needle point, but it's insulated almost all the way down to the tip, except for like, yay. So anyways, and you'll see that they have like a big suction tubing up here to kind of capture the smoke as we go here. See it there up there. They each have their preferences. You can see how one is using a towel clip, the other was using, forceps. Now, I don't know this for sure, but it does seem to me like, see all this wetness? It's really not bleeding. It looks more like fluid. This adipose looks really wet to me. One thing that they will do typically before liposuction is something called, they will inject tumescence. And tumescence is basically the nurse gets a big bag of saline and puts local anesthetic in it, and sometimes antibiotics as well. And they have like this special, it kind of looks like a lipo cannula, but it's for injection. It's just this long, skinny little rod, and you'll hook that to the tubing coming from the bag. They'll make a tiny little incision, and they will just kind of poke that into the adipose, like everywhere they're working. So that's going to, they typically put epinephrine in there as well, so that'll help with the bleeding, and it'll help with post-op pain control. Okay, so I'm guessing from all of this wetness, that's probably what they did before they started the shenanigans. Do they have their initials on each Bovie? I saw some writing on there. It's very interesting. Okay, so now they gotta stitch them up. That white stitch they're using is a Vicryl stitch. It is a multi-filament absorbable stitch. Here's the lipo. It's a very gentle procedure. Now they do have other special liposuction device that is like it uses ultrasonic waves to emulsify or heat to emulsify the fat to suck it out. So all of that jabbing is not required. This suture they're using for the skin is a nylon. It's a it's a monofilament suture. It's not absorbable. Those will have to be taken out later. That is some DuraPrep that they're using. So here comes the mastopexy with the, it doesn't show them place the implant, but see how they're skinning off. That keyhole was used to kind of make the lines that they're following. And typically what they'll do is they will go in to pre-op and they will draw all the lines on the patient. And then they come back to surgery. So when the nurse preps, nurse wants to make sure the prep isn't so vigorous that it removes the lines. That does not make the plastic surgeons happy. So next they got to make a pocket. Well, they're going to remove that excess tissue that was drawn by the keyhole marker, by the way. And then they have to make a pocket for their implant. So under here, this is pectoralis. Some surgeons put the implant under the adipose and some put it under the pectoralis. Rainey, to answer your question, I haven't experienced two surgeons working simultaneously together, but I have heard rumors that in the Valley there are like surgeons that are brothers that typically do their cases together. Most of the time you will have an assistant though, a first assist or something like that that's helping. The suture that they're using now is typical of plastic surgeons. It's called monocryl. It is absorbable. It's a monofilament. It's kind of like fishing line, but it makes a really pretty closure. And then they'll put the little sticky tapes, or sometimes they put staples, which makes it look ugly. Yep, it's a chop shop. What forceps is he using? Do you guys see it laying up there? Can you recognize that? That is a facelift scissor. That straight scissor that he or she was just using. So what's this? Can you tell what this retractor is?
Army Navy.
Yep, good job. So a lot of times with these procedures, when they get the breasts put back together, so to speak, they will want to sit the patient up on the OR table. So anesthesia will raise the back of the table so that the patient is kind of in a sitting up position so that they can kind of go down to the feet and get a bird's eye view and see if things are like symmetrical. Let me look at your question, Rainey. Yeah, it doesn't show the implant going in. It doesn't show that. But typically when he was like sticking his finger in there to kind of like open, I think that's when he was like just opening up the pocket, probably implant went in at that point. It didn't show that.
What about the scarring?
I'm sorry?
What about scarring and all this?
The scarring, good surgeons don't leave a scar, Jonathan. I'm just kidding. With plastic surgeons, and I can't remember the name of it right now, but part of their training is knowing the natural lines of the body and where they can hide incisions so that they will be least noticeable. So this inframammary incision right here, at some point, nobody will probably ever know that it's there. There may be a thin line here and around the areola, but for the most part, the incisions will somewhat disappear. Yep. That's a Webster needle holder. See how it's the little guy? So now the abdominoplasty. So the tour continues. This is an abdominoplasty. Typically make the incision way down, like iliac crest to iliac crest. A body overhaul, I know. She must have lost like a lot of weight, and they will cut around the belly button. If it is involved, they don't cut it off. They will make an incision around it. Yeah, see how they cut around the belly button there? This would be a very long surgery to do all of this. Probably 6 hours, I would say. So once they get this removed here, they're going to ask anesthesia to put the back of the table up just a little bit, because it is going to be a really tight, it's going to be a stretching to get this from here sewed back down to here. So they're going to sit the patient up just a tiny bit, and the patient's going to need to stay like that for a while. Eventually the skin will stretch a little bit to accommodate, but if they don't do it super tight, then it's going to look saggy pretty soon. A lot of times what they'll also do, I don't know if they're going to do it on this gal, but they will put stitches here to just tighten up this underlying abdominal muscle, some wider stitches to kind of pull that together to tighten up the tissue underneath before they actually sew it back. Throw that in the garbage. Or send it to the cafeteria, one or the other. Yeah, so see, I think this is gonna be, yeah. See how he's just putting in some stitches? Oh, send it to make soap. I don't know what he's using there. A lot of times they use Neurolon, which is a non-absorbable suture. It's pretty strong. That might be what it is, or it could be silk. There's the drain. So I have no idea what that is, honestly. This is a Jackson Pratt drain that will stay in the patient. Oh, I think that's local anesthetic. I've never seen that thing before. But it looks like it's injecting something, doesn't it? That's very strange. I guess. I'm not exactly sure what that is. I'm gonna have to find out. Now time to put the puzzle back together. Some more Vicryl. Probably the surge tech wielding those scissors. Came together pretty nice, I would say. Okay, that's our tour. Right, Alyssa? You're so right. Okay. Any questions or comments about anything today? I think that's about all I have for you.
Well, I was going to say my sister-in-law actually ended up having a tummy tuck done, and she had 3 babies, and all of them were humongous. I mean, every single one of them was 10.5+ pounds. And so she just was, it was awful. Like, she could put her fist plus part of her hand into her abdominal wall because the muscles had separated so much that they didn't come back together. And so they literally used like wire sutures. And so now, I mean, she has abs like nobody's business, but she's so thin, you can literally see like the wires now in her abdomen. I mean, I'm glad that she got it because now her guts don't protrude, but at the same time, I'm like, isn't there something else that could have been used?
And you're sure it was wire?
Well, that's what she said. But you can see it.
Yeah.
Like,
yeah, a lot of times when they will do that with the Neurolon or Ethibond, it's like really thick, heavy suture. And so if you're super thin, I guess there is a chance that, you know, that can, you know, it stays there forever or for a really long time. So, yeah. I don't know of any other options at this point besides suturing it, you know, to just tighten everything up. You know, it's like Dr. Hess was one of the plastic surgeons I worked with. And even when he would do facelifts, like he would take like, because they dissect the adipose off from the underlying muscle. And so he would cut like a little strip of muscle like out here and out here, and then sew, similar to what you saw for the abdominoplasty, because he's like, you know, if the underlying tissue is saggy, you're just putting tight skin over saggy underlying tissue. Like, it doesn't make sense to do that. So, you know, he's like, you always want to tighten up whatever is underneath before you tighten up the skin, or, you know, it's not going to be as good of a result or whatever. So, yeah. Anything else? All right. What do you have to do for your Blackboard activity today? Yes, post your Google Doc. Thank you very muchy. Don't forget to do that because I won't be able to give you attendance if you don't. And that's all I have. Yeah. That's it. For those of you that are coming to lab tomorrow, don't forget to bring your workbook and your time cards. Oh, and before you come, if you could, in this extra little time that you have, in your workbook, starting on page 230 is where the checkoffs start. So look those over before you come and just familiarize yourself with those if you could. It's the starting on 230, prepare gurney and demonstrate use. We have quite a few of them. Transport patient by wheelchair, assist lateral transfer of mobile patient, supine, lateral, and prone. So it goes all the way to page 243. Okay, so look those over before you come if you would. That would help out a lot. There's not a lot of information in this book. I looked in there, really doesn't go over, it just says transfer and transport. It really doesn't give any specific information. So your textbook and your workbook will be your two better resources for you, okay? Okay, sounds good. I will see some of you tomorrow. The others of you, we'll see on Wednesday, okay? Let me know if you need anything in the meantime. Adios. Thank you.